Hello, everybody in podcast land. I'm Dr. Ted Thatchencary, and this is MD Roundtable, a podcast about collaborating and learning from other healthcare professionals from all over the globe. We are all so much more connected due to technology. We have so much to learn from each other. Thanks for joining us today at MD Roundtable. This is a very special episode as we are featuring Dr. Alex Cedeno-Rodriguez, who is a thoracic surgeon at Advocate-Aurora Lutheran General Hospital in Park Ridge, Illinois. Alex specializes in minimally invasive thoracic surgery techniques, which include segmentectomy and minimal invasive sublobar resections for cancerous nodules and lesions. Welcome to the podcast, Alex.
Thank you for having me.
Fantastic. I appreciate you taking the time today, Alex. I know you're very busy, so thank you again for being here.
No, I really appreciate the invitation. It's an honor being here.
Great. Well, Alex, for our listeners, I always like to sort of go into your past and kind of find out where you come from, who inspired you, etc. So I guess the first question I have, Alex, is where did you grow up? Where's home?
So I consider home Puerto Rico. That's the place where I was born and raised. Most or all of my childhood, teenage years, and even like a portion of my early adulthood, I spent it in Puerto Rico. And especially there's a small town in the south portion of the island. It's called Ponce. Mm-hmm. That's where my family is at. My mom, my dad, and my sister, they're still there. So that's the place where I call home.
Great. So Ponce, Puerto Rico.
Correct.
I see. What was it like growing up as a child there?
It was great. Puerto Rico at that time was a very populous island. So people has this idea that you were born there, raised there, and you can die in the island without any major difficulties or problem because you have everything that you need. You have your family, you have your friends, you have excellent education. And growing up there, it was great. You can have a good day being at school, and that day in the afternoon, if you want to go to the beach with some friends, you can do that. If you want to go to the center of the island, and it will be more like a country type environment, you can do that. It was like a very nice experience growing up there.
That's brilliant. Thank you for sharing that, Alex. Do you come from a big family?
Well, in Puerto Rico, we consider our family, we consider our immediate and our extended family as our family per se. We basically don't exchange or interchange the word like close family or extended family. So we do. My grandfather, they are like 8 siblings, so in between brothers and sisters. So you can imagine like my grandfather generation, they're 8 plus every single one of them has about 3 to 4 children plus the grandkids. So it's kind of a big family. But my immediate family is I have one sister, mm-hmm. and then my dad and mom.
I see. So it must have been nice to have that just sort of family presence around you, huh?
That's correct.
Yeah, with your grandfathers, your grandmother, etc. So I'm sure you had lots of aunts and uncles that gave you good advice, huh?
Yeah, that's true. Just that coziness of the family is something that is very valuable,
right?
Especially when you grow up.
Yeah, and was education sort of a big aspect of how you were raised? Did they instill those values in you?
Yes, it was, and I always people like a very funny story, especially from my mom's side. My mom is an accountant, so everything in my house has to be like perfectly. So this is for clothes, this is for food, and everything was just like by the penny. Everything was just there. And then when we were at school, if they asked me, you need a book for X, Y, or Z, it doesn't matter. Like next morning, we went to the library and we get the book, or we have like any educational material that we need for school. In the same token, if I wanted like a video game or something to play with, there was no money for that unless it was your birthday or Christmas. So that tells you that like our family would do value a lot of education.
And did you go to college and medical school in Puerto Rico, or did you go outside?
I did a college and medical school in Puerto Rico. My college, I did it even in my hometown in Ponce. in the Catholic University at my hometown. Then I moved to San Juan, which is the capital of Puerto Rico, at the University of Puerto Rico Medical School. There is a big medical science campus that they have in the island. After I finished my medical school in the university, I did there my general surgery training, and then I moved to Albany, New York, at the Albany Medical Center in upstate New York, where I did my cardiothoracic or thoracic surgery fellowship.
In Albany, okay, great. Could I ask what that was when you were completing your thoracic surgery fellowship?
I finished in 2018.
Okay.
So it's about 5 years now.
I see. What inspired you to go into medicine and surgery, Alex?
I think, honestly, it has been like kind of a long process to trying to figure it out. Sometimes it seems to be like kind of a common story. When you ask someone why they went to medical school, usually the most common answer is because we want to help other people. And I think it's a very valuable and important topic to anyone who is on the medical field. And in my case, it was that when I was a kid, I was introduced to the Boy Scout movement. And at that time, they teach you a lot of things on the movement, or at least I was taught a lot of things in the movement. I was taught about leadership. I was taught about service. I was taught about giving yourself to others. And that's something that it was part of me since I was a very young kid, like even a first grader, when they consider you what we call a Cub Scout. Having said that, when I became older, I became very interested in math. And I thought I was going to be an engineer. I thought the idea of being a mechanical engineer was something good. So there was a summer camp in one of the universities at Puerto Rico. So you can figure that out if that's something that you want to continue with. And at that time, I figured that even though I liked math a lot, it was not something that I saw myself for growing old, being an engineer. So that's when I decided that medicine was something that I want to study, or I want to basically work hard to be a physician, especially when in my family there was no other person who has a medical degree.
That's outstanding. Yeah, that's very noble of you, Alex. Thank you for sharing that story with us. So for our listeners, Alex, can you explain the amount of years that you've had to put in to be where you are now, as far as your training goes in medical school?
In between the medical school training and the surgical training is about 12 years total. So basically it's 4 years of the medical school, 5 years of the general surgery training, and 3 years of the advanced thoracic or the thoracic or cardiothoracic surgical training, which in my case included 1 year of advanced training in thoracic surgery field.
Wow. Yep, that is a lifelong commitment and very demanding. I know thoracic surgery is probably one of the most demanding and challenging fellowships that you can do in medicine and surgery.
Yes, like right now, like the most specific, one of the most demanding things is because of the significant amount of work or time that you have to spend in the hospital, helping patients and having the opportunity to be trained. I think that's probably one of the reasons why it's the most physically and mentally demanding field.
Right. Alex, what have been some of your biggest challenges that you've had to overcome to get to where you are now?
When I think about that, I think probably it comes down to, believe it or not, self-confidence. There are times that you want to do something, and sadly, the first question that you ask yourself is should I be capable, or should I have the capacity to do X, Y, or Z? And me growing up, coming from a small town, small high school, if you compare my undergrad population to compare to a large university in mainland United States, it can be kind of challenging, you trying to find that energy because you really want to do something. So you want to try to find that self-confidence to keep going and keep moving on in the process, and at the same time trust the process. And that comes along to the fact that there are every now and then you found people that tells you that yes, you can do it, but in the same token, you find people that tells you, well, you might not be able to do this because of X, Y, or Z. So I think finding that fine line of being able to trust the process, have some self-confidence, and keep moving along, I think that's probably one of my biggest challenges throughout these 20 years, if you ask me.
That's amazing. Thank you, Alex. So I think it would be beneficial to discuss the minimally invasive techniques that you use in your practice, Alex. Can you tell us about the specific minimally invasive techniques that you use?
Yes. So when we talk about minimal invasive surgery, in all honesty, what it entails is like we do a smaller incisions on the patient skin. But when we think about the technical part of the surgery per se of what we do, if I give you an example of a patient who has lung cancer who might require either a lobectomy or might require a segmentectomy, the technical portion of it, even if you do the traditional open approach versus the minimal invasive approach, is a similar thing. What changes is what we do in the outside. There are multiple what we call platforms that we can do minimal invasive surgery. The way sometimes I describe to patients is like this: you have a smartphone and there are different brands. Well, it's kind of a similar analogy.
Mm-hmm.
Most of the time, what we use is what we call robotic assisted thoracic surgery or robotic assisted thoracoscopic surgery, which basically means that we have a very high quality or high definition camera that basically there's a robot that has the capacity to control the movements and you control the machine at the same time. And that allows us to do a very specific movements that mimic almost entirely the hand of a human. So it's like having your own hand. If you can like put it in like in a very small, you can decrease the size of your hands to a 5 millimeter instrument, and that's how that machine does the work, or is it like an analogy of how the machine works per se. And that helps us quite significantly because by using that robotic assisted technique, we can do very complex surgery, but we can still do the minimal invasive part. And that helps the patient expedite the recovery time of the patient so patient can go home sooner.
That's exceptional. Besides lung cancer and nodules, what else can you use that for?
So almost everything in the thoracic cavity, we can use it. Thoracic surgery, we categorize them. For example, one is the lung cancer. The other one is patient who has mediastinal masses, patient who has thymic tumors or have other forms of mediastinal masses. We can do resection of those patients. And also patient who has esophageal diseases. That includes patient with esophageal cancer and also includes patient with benign esophageal diseases such as hiatal hernias. And we can use those techniques to help those patients also.
Great. And can you explain to the audience about, this takes an entire team, correct, to accomplish this. So do you want to explain some of the other team members involved?
Yes, everyone, like when we go to the operating room, usually we make fun with the patient that we are basically like a NASCAR team. We have the car and then everyone is working to do something important. If you go from head to toe of the patient and everyone is very important in the team, there's no person who is not important. We have our anesthesiologist, and that also includes a nurse anesthetist every now and then who help with the anesthesia and keeping the patient calmed and adequately sedated and anesthetized for the procedure. We have two nurses. One of them is a circulating nurse, which basically help us making sure we have all the equipment that we need inside the room. And if the equipment, and if we need an extra instrument that was not planned, she's take care of that, making sure that all the nursing portion of the case for the benefit of the patient is well taken care of. We also have a bedside nurse, which also include a surgical assist. This is the person who is in charge that we have all the instruments in the table, making sure that everything is working appropriately. And we also have a physician assistant who is my right hand and is helping me directly with the patient. Because in this type of technique, I am operating the patient in a console that is about maybe 10 feet away from the patient. Mm-hmm. And then the physician assistant is the one who is close to the patient and helping with controlling the instrument that we're working with. So it's a big team. That's amazing. It's about a 5-person team. Yeah.
That's amazing. Yeah. And what about leading up to the actual operation? I know there's a relationship between thoracic surgery, where you are, and also interventional pulmonology. Is that correct?
Yes. So the way I see it is a superb team, or at least the one that we are trying to build right now. Right now, in our practice, we have one interventional pulmonary physician, Dr. Reyes, and he came along with a nurse practitioner. And those two gentlemen are superb as a person, and as providers and physicians.
Yeah, I know Dr.
He's a
Reyes. He was actually my first interview for the podcast, and I know Mauricio quite well. They're both exceptional human beings, very dedicated to what they do. So.
Yes, I mean, the collegiality that we have had and how the energy, the good vibes and energy for the team is just incredible. Basically the way that we work is it's a team work approach. Basically, we have a what we call a lung nodule clinic. So any patients in the region who is either part of the lung cancer screening program, or if they have incidentally been found to have a lung nodule because they went to the emergency room because they have a car accident, and and because of that, part of the workup included a CT scan of the chest, and incidentally they found a concerning nodule. Well, those patients, some of them come to our office or to our clinic. When we review those images together, and basically we stratify which patient we think are considered a high risk for having a lung cancer. When we make those stratifications, then the next step is usually a biopsy of that nodule. And that's where Dr. Reyes, or the interventional pulmonary physician, comes along with. They do the biopsy of the nodule so we can make a diagnosis. And depending on the result of that biopsy, and depending on the patient's physical fitness to tolerate surgery, then we proceed with the surgery. Having said that, we are trying to get that to a little bit of a more, or like an additional step in the process, because there are patients that we think that probably the way that we should do the biopsy is not through a needle biopsy, but through a surgical resection biopsy. So those patients, we take them directly to the operating room. But sadly, some of these patients, well, sadly, no, in a good way, because we identify these nodules early on, they are very small. And because they are very small, they are very difficult to feel in the lung per se. Mm-hmm. So nowadays, we have a new technology where the interventional pulmonary team, we can mark that nodule. We put a special dye system inside the nodule. And the robotic platform, the camera has a type of, we call it the firefly view, where we change the way that the camera looks at the lung parenchyma, and we can basically identify a green glowing object, which basically was the contrast that we apply on the lung parenchyma. And that guides me to find where the nodule should be and do the resection more accurately. So it's basically having it's a team approach all the time, mm-hmm. Between the IP service and the surgical team.
Yeah, that's such a great collaborative approach that you guys are doing. So thank you for the great work you guys are doing up at Lutheran General. I know they're lucky to have you guys down there. So.
No, it has been great. The last few months, it has been a very collaborative approach. So we are happy.
Yeah, in fact, I know that hospital very well because I grew up in Des Plaines, and that was sort of the go-to hospital, whenever like my father or one of us were ill, we were always taken to Lutheran General. So sort of brings back a lot of memories for me. So, but great. So having said that, Alex, what are some of the risks with using the robot versus standard approach?
So the risk of this approach for surgery is kind of a standard. So it is very similar to the open or traditional approach. Usually the most common risk are surgical site infections, even though it's small because of the smaller incision, surgical bleeding. Those are the two most common form of, if you ask, like complications that you can, or risks that you can have. But those risks are very standard, either in the traditional invasive approach or the minimally invasive approach. At the beginning, people were concerned about having, let's say, an injury to an important vessel and don't be close to the patient, that it might put the patient at a risk. I think that as the technology has improved significantly and the confidence in the technology has grown significantly, I think that the risk is very similar, if not the same, as an open approach. And I would probably say that even the risk of having a problem per se in a standard case is about either the same or less than a traditional invasive approach.
Great. And as far as length of stay goes, what's the difference in the length of stay of someone who has an open approach versus a robotic approach?
Well, that's something that it has been evolving throughout the years. The traditional approach, when we look at the literature, most of the time the data quotes 7 days as the average, as the standard. When the minimal invasive approach start to grow up and then we start getting more trust in the system, we decrease the length of stay from 7 days to 4 days. Now we are pushing even the boundaries.
That's pretty significant, would you say?
Yes, it's pretty significant. It's like half of the time. So it's basically a 50% improvement at the least. And now we are even pushing that a little bit further. And nowadays it's about 2 days in the hospital. And on younger patients, we have even been able to send the patient the next day. In patients who are like stronger, more physically fit, and the patient is doing well the following day, those patients, we can even send them home then the following day. But I should say that probably a 2-day hospitalization day is usually right now in the vast majority of the robotic assisted surgeries is usually the average.
That's outstanding numbers. Thank you. Alex, what has been the biggest challenge that you've had to face in this field?
In all honesty, I think one of the biggest challenges is that every now and then you want to try to offer in a patient who has a surgical indication, especially those patients who has lung cancer, you want to be able to offer them surgery to all of them. Sadly, that's not the case. The vast majority of our population, the age range goes from 65 to 75-year-old. And even though nowadays we have that population is a very strong elder population, our population per se is a population that comes with plenty of medical challenges. Most of these patients are diabetic patients. They have severe coronary artery disease, and most of these patients, or the vast majority of them, the reason why they develop cancer is because they were smokers for a very long time. And that has a direct effect on the patient's lung function capacity. So sadly, some of these patients are frail, and the challenge is like you want to offer them surgery, but sadly, none of them are surgical candidates. Every now and then you try to push the boundaries a little bit, even though the patient might be considered a moderate risk for surgery. Now you probably, you talk to the patient about what are the risks, what are the benefits, and those patients, you can get most of them through the surgery and recover well. But I think it's kind of a challenge trying to find or try to get most of these patients through the surgery when you know that most of them, they are frail, and sadly, not all of them, they can go through the surgery.
I see. And Alex, if you've had a say, what's a tough question that you've had to ask yourself lately?
Well, it all depends on the day, if you ask me. When I am tired, when you have to make very difficult decisions throughout the day or the week has been tough, every now and then I just sit down in my house, in my couch, look at the ceiling and ask myself if I have a time machine and I can go back to my college years, if I should go through this process again and be here again. And I think like that question sometimes becomes louder in your head, especially with the constraints of the health system that we have faced probably throughout the last 3 years, and the challenges that comes along with it. I think that's the biggest question that sometimes I ask myself, because in our field, sometimes people think that the only burden that we feel is just the physical one, long hours of work. You're out of your house for 10 to 12 hours. Then you go back to your real life, family, etc. But I think more than that is the mental challenge, trying to help patients, trying to find the right answer all the time when you know that you don't always have the right answer, and trying to always execute to the best of your capabilities, even though everyone has a good day and a bad day. And that question on those times becomes louder. But when the day is over, the next day is up and something good happened, you basically change your mindset almost immediately. And the answer always becomes more clear that, yes, I will do this again in a heartbeat without any difficulties.
Yeah, that's great. Thank you for sharing that, Alex. That's a good answer. I guess self-reflection is important, especially in medicine and surgery, right? We tend to do that all the time and question if, we're doing the right thing. Is this where we should be, et cetera. So I know exactly what you mean. And somebody once told me that, there's nothing wrong with failing, but you should look at it as failing forward instead of
Exactly right.
of failing backwards. So
Exactly right.
Great. And Alex, how do you continue to stay up to date in this field?
So I think the answer is like reading a lot. In the thoracic specialty, they're one of the multiple societies that they have. One of them is the what we call the Society of Thoracic Surgery. And I have to say that in the last few years, the educational portion of that platform has been very robust and has been very helpful, I think, for every provider. There's an annual meeting, as most of these medical societies, but also they have a constant webinars, they have the journals, they have even an online electronic book that every few months the chapters gets updated. Which is extremely useful because, as you know, sometimes most of the books, they are like 5 years behind to what is currently happening. But now with the technology and the capacity of being able to update those chapters, I think is becoming more like updated. Like literally, you can read update material every month without any major difficulty.
What book are you referring to, may I ask?
Yep, this Society of Thoracic Surgery. The book is called the Pearson. It was a book that was there for a very long time, and then what the society did is that they put the book online, and then every 3 months, if there's a chapter that they think is not updated, they ask the authors and the editors if they can edit it, and then when you log into the electronic book, it says that you have an update available. So you update the book, and all of a sudden you check what was updated, and they tell you this chapter was edited. So it's kind of a neat
That's great.
System that they have.
Great. What are some of the things that excite you the most right now in this specialty?
You know, what excites me the most especially is the fact that the field is trying to update itself every single time. What I mean by this is like it was very interesting when I was in general surgery and I was trying to apply to cardiothoracic surgery or thoracic surgery. There were many people who thought that the field was getting old and that they were not getting updated. And there were even people that talked or said that the thoracic field was like a dinosaur in the medical field or the surgical field. But when you enter the specialty and you see all the things that has been done, I have to say that that's way far from the truth. In the thoracic oncology or the general thoracic field, the transition to minimal invasive surgery has been superb. Right now, when you compare the field to probably 10 years ago, I think about 70% of the cases or the surgeons who are practicing thoracic surgery are doing it minimally invasive. Most of even the old surgeons are trying to change from doing open surgery to doing robotic surgery, which is kind of a very good thing to happen. If you add also the fact that now in the cancer field, there has been a lot of new trials that we were waiting for that just came out regarding how to help patients who have lung cancer. I think that evolved of the field constantly. It excites me all the time in the fact that really the field is not a static field. It's a field that is moving forward and forward all the time.
That's great. Yeah, I know that there's a push as well for minimally invasive bypass surgery as well, correct?
That is correct. And the field, in the cardiac portion of the field, they are moving more to doing a cardiac bypass either minimally invasive because they do a small sternotomy or because they use the robotic platform to use the bypass per se.
That's great. Alex, having said that, what are some of your interests outside the OR? How do you like to decompress?
The interest per se, usually I like to spend time with my wife. We usually, when we finally get a weekend off at the same time, because sometimes we don't have the same schedule. Basically, we don't do anything crazy. We like to sit down, talk. Sometimes we do a lot of restaurant hopping, just to sit down and find like a new environment to be at. It's something that we enjoy a lot. It's our talk time, and we really enjoy that. In terms of decompress, I think when I was a teenager, I got involved in going to the gym. I do weightlifting. And even though time's constraints and when you get older, there's other responsibilities, but still throughout those times, it became a habit. And the 45 minutes or an hour that I am there with hearing some music, it's literally my decompress time. I feel that I enter in a way. And when I come out, I feel that I am completely refreshed. And because I know that I that's basically my decompressed time of the day if I'm able to do it.
That's great. Yeah, definitely got to make time for yourself, right?
Yeah.
You mentioned restaurant hopping. What's your favorite food to eat?
Well, I used to like a lot of steak, but I like more now seafood.
Mm-hmm.
It's kind of really, so I like a lot of seafood and also a lot of Italian and pasta.
Ah, very nice. Alex, if there was one thing you'd like to say to your colleagues in the specialty, any message or thoughts for other professionals in the specialty right now?
I think the message will probably, it's kind of a complex message because I think we have to, at some point, I think we have to look back to the fathers of medicine, why they did medicine to help people and to look like very high to our profession. It doesn't matter what field you are in medicine. The reason I say this, because for some reason I feel, and including myself, that after 2020, when we have the medical constraints because of the pandemic, we are paying a lot of attention to physician burnout and about physician quality of life. And even though that's a real thing, that's something that I have seen personally in colleagues, I think that if we found a way to be the medical field and we found the time to be where we are, that means that we as a group of physicians, we know how to manage our time adequately, because that's the only way that anyone have been able to make what we all have passed through to be where we are at. Having said that, I think that looking back to the reason why we did medicine, sometimes sit down and look at the foundations of what we did, probably will be a little bit of help and be useful to keep us doing the job that we do and make sure that we do it in a high quality level. Because at the end of the day, we don't do it for ourselves. We do it for the patient who is across either the desk or is basically in front of you if you are in the hospital. And I think we should not lose that hope. Sometimes when we talk in the hallway, we talk to our colleagues, it feels every now and then that as a group of physicians, we have lost somewhat of a little bit of the hope on the system and on how valuable we are to the system. And I think we should try our best not to do that and basically go back to the foundations of how medicine became such a good field in terms of like a profession, and use that as our anchor or as our foundation, just to keep doing a good job and to make sure that our generation becomes a good example for the newest one that are either in high school that want to go to med school, or either are already in med school and they want to do any of the surgical specialties.
That's great. Yeah. Thanks for that answer, Alex. Alex, are there any conferences or webinars that you will be at or presenting in the near future?
Yes, we have a webinar in conjunction with Dr. Abdullah Reyes, which is our colleague from the Interventional Pulmonary division. It's going to be Thursday, May 11 at 7 p.m. on Eastern Time. It's part of the webinar program from the Society for Advanced Bronchoscopy. And the title of the conference will be Single Anesthesia Event for Lung Nodule Marking and Minimal Invasive Resection. If you search in the web the Society for Advanced Bronchoscopy, automatically you will have the society website, and in the webinar portion of the webpage, you should be able to find the link for the event.
Great. And I'll be sure to include the link in the show notes as well, Alex.
Oh, that's great.
So, Alex, I just want to thank you again for being on the show and sharing your story and your journey. Props out to you and the entire thoracic surgery team at Advocate-Aurora Lutheran General Hospital. You guys are doing great work, and keep up what you're doing, okay?
Oh, thank you. Thank you so much.
Thanks, Alex. Have a great day.
You too.
Folks, if you enjoyed that episode, don't forget to leave a review of the MD Roundtable podcast on Apple iTunes, and please don't forget to subscribe. Stay tuned for our next podcast coming to you soon. Thanks for joining me again, and have a great day, folks.